All right, ladies and gentlemen, thank you so much for patiently waiting. Our speaker for tonight, Dr. Henry, is live with us. Ladies and gentlemen, presenting to you, Dr. Henry.
We are speaking about the immediate loading in the atrophied bone by a minimal invasive procedure. So you see, my name is Henry Diederich and I'm from Luxembourg. So we are speaking about a new approach, cortically fixed at once. What are the objectives of cortically fixed at once? The objectives is the restoration of vital function and characteristics in difficult and extremely difficult anatomic situations using a minimal invasive procedure. A root form implantology only approach, for example, may require prior modifications of the bone anatomy using grafting procedures before implant placement is feasible. Or cortically fixed at once enlarge the scope of implant dentistry without requiring recourse to complex techniques such as destruction, bone splitting, grafting, or prior to implant installation. So there are different publications about this subject I did just to show you the publications. And then let's see the definition of the atrophic jaws. In the atrophic jaw, we have 100% basal or cortical skeletal bone and no alveolar bone. We have a type 1, which may be a higher density, a type 4, which may be a very low density, and the characteristics are following. We have 99% hydroxyapatite and collagen of type 1. We have 1% living cells only, which are osteocytes. You have a poor blood supply in the bone structure. You have blood vessels which are located mainly in the surrounding soft tissue, and you have a bone height from 1 to 8 millimeters. So we have the classifications by Cavut, which shows us the quantity of bone present, as well in the anterior mandible, posterior mandible, anterior maxilla, and posterior maxilla. We know also this peak about the bone resorption in maxilla and mandible, in quantity also. So at the left side, it's quite easy in normal implantology. At the right side, it becomes difficult. We have small bone volumes where above the mandibular canal and beneath the maxillar sinus. So here, this is a male of 63 years old. Treatment options. What are our possibilities? Or here, this female, 61 years old. What is our treatment option? Well, we may adjust anatomy by Calvarian grafts, by sinus floor elevation, by crustal split, by iliac bone grafts, or by nerve displacement. We may harvesting the bone from the skull, like here, which is a classical procedure. Here you see, we take the bone from the skull. That is an opportunity, it is a treatment option. That has to be done in a general anesthesia, and it takes time. And also for the patients, it's not so nice. Or what may be done on the other side, we may adjust implants. So when we have atrophied bone, we may use zygomatic implants, we may do all-in-4, we may do trefoil system, we may adjust implants by CAD-CAM, or here also by CAD-CAM, or we may do cortically fixed at once, CF@O. Now, let's just speak about titanium. Titanium was discovered in 1791 by an English chemist, William Gregor, and in 1939, it was a Luxembourgish, and I'm very proud about this, scientist, William Kroll, who discovered the titanium production flow sheet, which is still used today. Titanium in 1937, when it was first produced, seemed pure fantasy. But today it has become what its name prophesied, a titan, said Kroll in 1963. And the genius of the inventor is made up of 99% of transpiration and 1% of inspiration, as quoted by Kroll in 1956. And then what he said, I fought against the stupidity of leading men more than I struggled with the periodic system of elements, so said by Kroll in 1956. That is our logo, that is the brand, and the brand is born in Luxembourg in 2015. So what are the goals of cortically fixed advance? We have a primary stability, we have an immediate loading, minimal invasive, and we may avoid bone augmentation. We have the vertical pillars. We have compact bone. You see the anterior canine pillar and into the lateral zygomatic pillar and then posterior pterygoid pillar. And it is there we will use our anchorage for our implants. So let's see how it works. So you see, we are looking for a vertical pillar in the face on your left side. And here you see our plates, which are used to fix on this part of the bone, because that is a strong cortical bone. You see here, we fix the plates. And the plates are adapted to the bone, and they are screwed with osteosynthesis screws. Now, I invented this plate, which is patented, which is highly efficient and no graft care anymore. We have four different plates: a HENGG-1, a HENGG-2, a HENGG-3 plate, and a HENGG-4 plate, which is also patented. And then here you see the application of these plates in the maxilla. The specificity of these plates, they're highly flexible, they're in grade 2. And then you see, you adapt them always to the individual situation of the bone of our patient. They are fixed with screws. You may have screws with special surface treatment. And also the plates are treated on surface. And here you see, they are strongly fixed, one part in the zygomatic bone and the other part on the palate. And here is the real skull, how it works in reality. Another time, the hybrid plates, they are fixed here in the maxilla bone. And here, another view. See on your left side, you see a special bed is prepared to receive these plates. And then what happens? That is so wonderful about this, what nature is doing. Bone is growing over this plate. So here, we are not speaking about a subperiosteal implant. No, we are a plate which have to be integrated or which integrates in the bone. Look here, this peak, or here also in the maxilla, the bone is growing over the plate. And here also, another time, a perfect integration of this plate. And we are doing this by minimal invasive procedure because we rest on the bone. So what are the principles of cortically fixed advance? We have a multicortical implant support. We have the anchorage in the major cortical bone pillars of the jaws, zygomatic process, pterygoid plate, canine pillar, vestibular and buccal corticals, and in the torus nasalis. And we have an absolute primary implant stability in dense living bone by using specific implants. Here you see one type of implants, and also, which is so important, are the pterygoid implants, because the pterygoid implants give us the anchorage in the cortical bone. Here you see a posterior view of the maxillary tuberosity with the wings of the sphenoid, so which is our cortical area of the pterygoid. And then here you see on the right side the fixation of this implant, this pterygoid implant, which anchors in the cortical bone and which is anchored in the pyramidal bone and in the wing of the sphenoid, which is our pterygoid. So we have current definitions of pterygoid implants. Now, throughout literature, several terms are being used to describe pterygoid implants. The terms pterygoid implants or pterygomaxillar implants and tuberosity implants are used interchangeably. But pterygoid implants have been defined by the glossary of oral maxillofacial implants as implant placement through the maxillar tuberosity and into the pterygoid plate. So, And there are significant differences between pterygoid and tuberosity implants, including the following. Pterygoid implants originate in the tuberosity and engage in the dense bone of the pterygoid plates and palatine bone. And the tuberosity implants originate in the maxillar alveolar process and can occasionally anchor in the pyramidal process. So the bone quality in this region is mainly composed of type 3 or 4 cancellous bone. So you see then our pterygoid implant, and the preferred position, of course, is in the medial wall of the pterygoid plate. So here, in this ideal case, the implant is fully engaged in the cortical bone. You see here the position of the implant. Or here, this also may happen. That is not the point. Here we are in the pterygomaxillar fossa. So here you are in the muscle. That's not an issue. That's not a problem. What will happen with time? Bone will grow around this implant because, you know, osteoblasts are in love with titanium, and there will be an osteointegration, and that is so strong anchorage you cannot take it out anymore after. And then you see, don't be scared, because of course, if you want to put the pterygoid implant, of course you have to know the anatomy, you have to know the know-how of this placement, and it will be really an added value for your daily practice in implantology, which may avoid sinus lift and another time bone graft. You see here the insertion direction. The target is the medial wall of the pterygoid plate, and you may prepare a stereolithographic model of the patient, and you may train. This is a way how to learn it before. And then here you see our visualization of the pterygoid implants. Now, personally, I do it always freehand, but also you may do it by guided surgery. So for beginners, it should be interesting to do it guided in order to be sure. But you see here, left and right side were done at the same level freehand. Let's come back to our plates. You see here is a presentation of the plates. And then we have different options, and the options another time are depending about our bone situation. We have a lot of bone or not bone, and the decision is taken always regarding the presence of bone. You may have this option with more different plates. You see here in the maxilla, you have two HENGG-1 plates, you have HENGG-2 plates, and then of course where you have bone, you put a normal implant, maybe a one-piece or two-piece implant, and of course in the protocol you must use your pterygoid implants. Here there was more bone, and here too. So here there was just a bone atrophy in the maxilla. There was enough bone in the front, and then we may put, of course, one-piece or two-piece implants. Of course, always advocate the more easy way to do. Or here, very often the bone quality is also very bad in the anterior part, and then it is important, you see, that you have more possibility to anchor your plate. More possibility you have, better will your result. Here in the front, you see, I could put four screws. That is wonderful, but it is not always possible. And here you see there was a big atrophy in the maxilla. In the mandible, it was a little bit more easy. Here, absolutely only possible to put plates. There was no bone at all, so I could not put one-piece implants. Yes, but I could pterygoid implants. Or here, these different options. But as I told you, it is all depending on our bone situation. So let's see now some cases like a total edentulisme, how it may work. So this lady, 57, came to me with a bone atrophy in the maxilla, and this case was done in 2012. So she had a total prosthesis, you see on the left side, with this Insertion, and then the final result was a metal ceramic bridge and the placement in the mouth. So, and then that was done in a very short time. In general, we finish our work 10 to 12 days. Surgery was done under local anesthetics, so I do all my surgery under local anesthetics. And here you see that was the final result. You see pterygoid implants, you see hybrid plates. There was also here disc implant, and then one-piece implants were in the anterior part where the bone is. And here's the result in 2017, and here in 2019. So what is then amazing about this case, and in general all these cases, it is done in one shoot surgery, and the cases in general are finished after 10 days. It is depending now if we are doing a temporary bridge or not, but in general, mostly I finish immediately with metal ceramic bridges. And then here, the smile of our patient, and our patient was happy, and that was the result. Here, another case, so this was also a young lady, and you see she was very unhappy about her prosthesis, total prosthesis. There was no retention. And then the colleagues, of course, they offered sinus lifts, they offered bone grafting, which took a lot of time, and general anesthesia, and yeah, the patient did not like. So what may be our treatment plan? Remember, you see the plates. We are adapting our plate. On the left side, it is delivered like this, and it is like a device done on measure. You see, adapted to the bone. It's fixing. You may bend it, and then it is fixed on the bone. You see here the protocol: pterygoid implant plate, and then the screws. The different plates, HENGG-2 and HENGG-1. And impression is done immediately after the surgery. We are doing a temporary bridge. And here in this case, the finished bridge was settled already 10 days later, but for financial reasons, we did here a metal acrylic bridge. But here you see the result after 10 days. So the protocol here was pterygoid implants and 4 plates because there was no more bone. And it was done in a minimal invasive procedure. And here it was some years later, in October 2019. And also here the patient was fine, no problem all over the years. And here, teleradiography, you see how it is done. Another patient, 79 years old. So, of course, when you have a limited age or when patient is older and he wants to have fixed teeth, so the case was done in 2017. And then you see 2 weeks later, the placement of our bridge, and a happy patient because it was done in very, very short and fast time. And here you see the structure. And here you see the prosthesis in mouse. We keep space, that cleaning is possible. And then here also it was done metal acrylic because that was also a question of price. Well, this patient, 60 years old, he wanted fixed teeth in the maxilla. Also bone conditions was very bad. And here we fixed then different type of implants. Here we could use 2-piece implants. We put the plate. And then after 10 days, you see, we fixed here we prepared our bridge. That was a frame. And here was the finished work. And here was the finished case. So also here in a difficult case, it was possible to realize fixed bridge after a very short time in a minimal invasive order. Or here, another patient, which also was done by the same way. Well, this patient, the lady, she came with a broken bridge in September 2018. Bone conditions also were very bad. And situation in mouse. So you see, we took out the bridge. You see the situation. It was really not good. Of course, we have different treatment options. And here we have a very thin width, see on your left. And always the treatment concept is the same. We are beginning with the pterygoid implants. And you see here the pterygoid implant is in place. We are adapting our plate. And the HENGG-1 here, you see it is fixed. See the cortical anchorage on your zygomatic bone. And then in the palate, a maximum strong fixation with 4 screws. When there's no other bone possibilities, we are taking HENGG-4. You see more anchorage points. And on the other part, we fix it and it was done. So here we went through a temporal bridge, and that was the day of the impression for the definitive bridge. We did the solidarization of the transfers. We did an aesthetical try-in. Another time we tried the try-in. We did another impression to be safe. That was before placement. You see the model on your right. You see the mouth soft tissue before placement. And then you have here the bridges, machined bridges. That was a metal resin try-in another time. And here was work in progress. You see here our pterygoid implants, our two-piece implants, classical implants, and then where there was no bone, we could put our plates. And that was the day of placement. And our finished metal ceramic bridges, we did it here in two parts, on the left, on the right part, and see also how is the finishing on the pterygoid. On the pterygoid, we have no tooth, we have just a fixation point. And that was the finished bridges in mouth. And that was the day of placement. And that is a finished case. So in the second stage, we did also crowns in the mandible, and that was a happy patient. Here we have a patient of 71 years old, and we have 4 years follow-up. So treatment plan. So you see here our X-ray. It was like this, but aesthetically it was like this. So the lady, 71 years old, she was a little bit unhappy because what may be the issue? How many time it will take to treat me? And so on and so on. So you can imagine, we did here extraction of all the teeth, and the protocol, the pterygoid implants, hybrid plates were prepared, impression after surgery, and here metal ceramic bridge was placed immediately 10 days later, and that was after 2 weeks, our placement. And you see our X-ray, our pterygoid implants, our plates, our one-piece implants, our pterygoid implants from the lateral view. And here, 4 years follow-up, there was no problem, hygiene is perfect, no pain, no swelling, patient is just happy. So that is excitement, because in a very short time, we may do a treatment plan, and we have a result. And that is what patients are looking for: a fast result, a minimum of suffering, and to have fixed teeth. Here, this lady also, she was very unhappy. You see, 66 years young or old, and she was very unhappy because the doctor told her, you will get a fixed prosthesis. Yes, but for the doctor, it was fixed on 4 implants, and for the lady, at the end of the day, it was a removable prosthesis. So the patient was very unhappy. And you see, the problem is, the colleague, he could just work on the anterior part because there was bone, and as he was not trained in sinus lift, on bone grafting, he did do nothing else. But the patient was very unhappy, and she wanted fixed teeth. So you imagine now in this situation to have a treatment with a very fast result. You will put them with implants. You will put here your hybrid plate. We took impression and the model. We did a trying in with the frame, and then here 10 days later already we could settle with a metal ceramic bridge. See the placement. Also look your pterygoid implant another time. It is just fixation. There's no tools, because otherwise it is a problem for hygiene. So it must be easy to clean and to support. And here placement 10 days later, and our result, a happy patient. So we could solve this patient in a very fast way. And here also another time, see the angulation of your pterygoid implants, freehand, and the result after 10 days. The patient here, 45 years young, she wanted to change her look. We see the X-ray in the maxilla. Yes, periodontical was not good. So what to do? You may imagine we did extraction of all teeth and we put our plates where there was no bone. We put terygoid implants and we put compressive implants for immediate loading in the anterior part. We could take the impression after the surgery. Impression was done. We did a try-in after 4 days or 5 days. The framework, we did try-in with the framework. And here it took a little bit longer, 2 weeks before placement. See our soft tissue. And our metal ceramic bridge was realized and was placed. And here was result after the placement. And here, 15 months later, also, no problem, all well osseointegrated, no complications. So the patient was happy. Here you see the day of the placement, the gum was still a little bit irritated, but after everything was fine, and our patient was happy. Here also, patient of 60, she wanted fixed teeth. She was very unhappy because it was big atrophy in the mandible. It was big mobility of the prosthesis and what to do. So we decided to put fixed teeth. And here you see on the left side, the mandible nerve was nearly on the maxilla. Here we have to prepare the bone because, as I told earlier, we have to prepare a bed. We have to prepare a bed to put our implant because our implant should be osseointegrated. And you see here how it is done. The implant is prepared and then it is put in the bone in the order that the implant, that the plate will be covered with bone. And bone will grow on it. Impression, and here final work, metal ceramic bridge, 10 days later, day of the placement and adaptation. That was done in 2014. And then here you see how it works in 2017. So everything was perfect and is perfect. And here in November 2019, in the meanwhile, the maxilla is also done. So here another time, minimal invasive treatment in the big atrophy and fixed teeth. Another patient, 71 years old, had problems in the mandible. Of course, you know, we have different treatment options, especially here on the left side, there was peri-implantitis. We took out all teeth. You may imagine, also the implants were extracted. We put a HENGG-4 plate and compressive one-piece implants. That is from company which is that are root implants or trade company. And here is the impression, and we are doing a temporal bridge chair side. You see the soft tissue before installing the bridge. Look here around the plate, how well is the tissue and how well everything is healed already. And here you see the finished case 10 days later, and it was done. So now let's see unilateral and bilateral. Because what is so wonderful in this technique, we may do all cases, not only like all in four, you need, of course, a maxilla, a total maxilla, but here we may work also partial and bilateral, unilateral, or total. So this patient, 54 years young, he wanted to replace his broken teeth on the left maxilla side. Case done in 2012. Of course, you have different treatment options. But here, what we are doing, we are taking out the teeth, we are putting the plates, a framework 5 days later, and then the finished work in place. So also here, we were very efficient because in a very short time, our patient could receive our fixed teeth. And see also another time the angulation of the implant. Or here, the patient of 62, she had a broken bridge in the right maxilla, yeah, but she was a professor and she did not want to stay without teeth, but the bone was a very bad bone quality. It was a D4 bone. So we are putting a pterygoid implant, and of course we are adapting a plate. And here, 10 days later, we could settle our metal ceramic bridge. You see the soft tissue, you see the finished word, and here you see how it works on our X-ray. And another time, we could settle this patient and finish it in a very short time with a very efficient result. These are very difficult cases because you see it is bilateral and she got missing his teeth, and this case was done in 2013 already. And then you may imagine, we are bending the implants, we are fixing it here in the mandible, we are preparing the bed, and that was a finished case 10 days later. It was done in one shoot surgery under local anesthesia. And here you have 6 years later, the result, everything is still in mouse. There's a little change on the left mandibular side, but everything is fine, no complications, and functional. The patient here, a young lady of 45, she wanted fixed teeth at your right maxilla side, and you see there is no bone. Another time, we are bending our plates. We are adapting, screwing it, fixing it. Here we had to use 2 HENGG-4 plates. We are covering it with a bone substitute. And here the result 10 days later fixed in the mouse. This lady, she wanted fixed teeth in the left mandible. Also here it was critical because there was not a lot of bone height. We did cemented and screw retained. Cemented because we used here 1-piece implants in the front in position 35-36, and then the plate. And 10 days later, we could put our bridge, and it was done. Another patient of 40 years old. The plate, they may be cut if they are too long, so they are adapted. The plates are in place. Impression and the framework. You see the model here. It was a mouse situation. Before placement, also soft tissue, nice sealing around the soft tissue, and the placement after 10 days. And here you see our X-ray. So also perfect result, no complications, and a happy patient. Here, we did immediate loading versus delayed loading. The patient is 62 years old. Here in the maxilla, you see it is a very difficult situation. So on the left side, we still had some more bones than on the right side. So on the left side, we could go immediately for immediate loading. But on the right side, we had to go by delayed loading because the bone situation on position 40-15, there was not so much. And then I prefer to go by delayed loading. And here you see now the right side was done by delayed loading. But anyway, the patient was done by a minimal invasive procedure without any complications. Or here also, you see this patient of 60 years old had a problem at the right maxilla. The bridge was broken. And here also we did extraction and implantation. You see the implants in mouse. And here the finished case. Also minimal invasive procedure. See on the left side, on the right side, our pterygoid implants were doing a great job. Here this patient, he had problems of 58 years old. The CAN was done in 2016. You see from 22 to 17, we are taking the impression, we are doing our, we are first adapting our plates, soft tissue around the plate, and here 10 days later, there was a finished bridge in mouse and also a happy patient, and without any complication all over the years. So what about to say about the hybrid plates? So the hybrid plates must be installed with a multi-cortical anchorage because absolute primary stability is essential to obtain osseointegration that is maintained over time. The design and the dimension must permit the connection of the prosthetic components in a functionally useful manner to create a fixed prosthesis. And the occlusal forces transmitted via the future prosthesis must be properly distributed as not to exceed the breaking point of the bone and the prosthetic components. So loading protocols, immediate loading of full arch and partial arch restorations is possible using highly rigid prosthesis and is mostly screw retained. Anti-late loading is also recommended if the bone quality is not good. When we need a passive fit of the prosthesis, which is mandatory for satisfaction, mastication, and speech, and the use of a transitional prosthesis for a period of time may allow verification that functional cosmetic requirements are met. Anticipation of potential problems is also an important factor for the long-term success of quarterly fixed restorations, and the knowledge and experience needed to satisfy these requirements cannot be improvised, nor can they be acquired without appropriate theoretical and practical training. Statistics now, I inserted from 2012 to 2020, in total 432 plates, failure 5 in the maxilla, 5 in the mandible. There's a publication in progress about this. For colleagues who are interested to do a training, a course, now online courses are now disponible. You may have a look at info@corticallyfixed.com. And there's also a special lunch, following the lunch of our online course platform. You may see this because you have an online training course for the cortically fixed, but also an online training for pterygoid implants. And you may really learn how to put the pterygoid implants. You will learn the anatomy, the placement technique, and also video is showing you how to do it. So that is unfortunately our COVID, who is actually doing progress all over the world. Hopefully we will find very fast some issue about this. And thank you very much for your kind attention. And another time I want to apologize to join you a little bit later because I had some technical issue. So thank you very much.
Thank you, Dr. Henry. All right, Dr. Henry, it's time for us to start with the question and answer session. We start with the first question. What is the success rate of immediate loading of two-piece implants retained over denture opposing maxillary conventional denture?
Yes, you want that I answer or that I tape the answer here?
Sorry, sir?
Do you want that I give response or that I will answer by writing?
No, so you can say it by response.
Oh, okay. So two implants, yes, it is depending. It may be successful as it is not successful. In general, I prefer to put 4 implants or minimum 3 implants because it's just depending. But this is a question of price and question of disponibility of patient, of course.
Thank you, sir. We move to the next question. Is the plate used to splint the implant, or is the plate itself acting as a subperiosteal implant? Is the plate custom made, or is the plate fitting once as all rule?
So first, you must splint the plate. The plate never may be used as a one piece, as a one implant. You see, it must always combined with other implants. Never use it for a single atrophy. For instance, when the molar is missing, you have atrophy and you want to fix the plate. That is absolutely not the indication. And then it is machined. So it is not custom made because all the plates are the same length, and you have to adapt it on the patient.
Thank you, sir. We move to the next question. What is the post-operative clinical precautions after placing basal implants to patients? And is it indicated as a precautionary medication? Thank you.
Now here in this procedure, of course, I give antibiotics. And I give also cortisone to avoid swelling and pain. So, but here mandatory is to give antibiotics.
Thank you, sir. We move to the next question. What points we should remember while planning the pterygomaxillary implant placement in posterior atrophic region?
That is a very interesting question, because you see, putting a pterygoid implant, you must learn it. And to learn it, you must learn the anatomy. That is the most important point. Why it is not popular? Because it is not taught. So now I give teaching about these pterygoid implants, and once you know how it handle, it is absolutely not a problem.
Thank you, sir. We move to the next question. What, according to you, is the best implant? Is it the conventional two-piece implants or is it the basal one-piece implants?
For this, I give you the answer. Case selection, patient selection. For me, a one-piece implant is an added value to the traditional implants. You cannot do all cases with one-piece implants. But the problem is all practitioners who are working with two-piece implants, in general, they don't know the one-piece implants. And that is a big lack of knowing, because it is really an added value. So you cannot say this is better than this, it is additional.
Thank you so much, doctor. We move to the next question. The question is smoking a contraindication for basal implants?
No, absolutely not.
Thank you so much, sir. Any more questions, friends, before we wind up the session? Okay, all right. What is the failure rate of basal implants?
Now, when we are speaking about basal implants, we must know which type of basal implants we are speaking of. Because I know in India, for instance, basal implants is a one-piece implants. Here in Europe, a basal implants may be a plate. So that is a question of differentiation. So I cannot give you the answer for this, because myself, I don't work here in Luxembourg with basal implants as they are used in India.
Thank you, sir. Last question from the session. If one basal implant fails, do I have to remove all the other basal implants?
No, not at all. No. So it's not a reason.